and I want to welcome you to the webinar, Spirituality and Mental Health, What Clinicians Need to Know, sponsored by the Iowa Department of Public Health, the Iowa Gambling Treatment Program. The Iowa Gambling Treatment Program works to reduce the harm caused by problem gambling by funding prevention, treatment, and recovery support services for Iowans. Today's webinar is presented by David H. Rosmarin. This is the first webinar in our 2018 webinar series. If you're looking for more information on those webinars, you can visit the Training Resources website. The series is called Looking to the Horizon, Trends in Problem Gambling Prevention, Treatment, and Recovery Services. If you are having any difficulties hearing the presentation or any difficulties besides that, you can send me comments in the chat box or a question in the question box. You can also call our office at 515-309-3315 and we'll figure out to help you. You are going to be able to participate by asking the questions in the question box, and we will take some time at the end. Dr. Rosmarin will answer your question, so please be specific so he knows exactly what you're referring to and can understand correctly to understand and answer your question. And then we are also going to be doing some polls, so I will pop those up and you'll have the ability to answer the question, submit your answer just through your computer. And then once most of you have answered, I'll go ahead and close those. Our goals for today's webinar are to learn about the relevance of spirituality to mental health and its treatment, how to formulate spiritual resources and struggles in clinically meaningful terms, and how mental health can be addressed through integration of spirituality into the treatment process. I'm going to now introduce David Rosmarin. He is the director of the Spirituality and Mental Health Program at McLean Hospital and an assistant professor in the Department of Psychiatry at Harvard Medical School. He is also the founder and director of the Center for Anxiety, a private outpatient clinic that has offices in Manhattan, Brooklyn, and Rockland County, New York. Dr. Rosmarin is a clinical innovator whose work on integrating spirituality into cognitive behavioral therapy has wide acclaim. He is also a prolific researcher, having authored over 50 peer-reviewed publications and over 100 abstracts. Dr. Rosmarin's clinical work and research have reviewed media attention from ABC, NPR, Scientific American, and Boston Globe and the New York Times. And now I'll turn it over to Dr. Rosmarin.
Thanks very much, Erin. I really appreciate all the work that you did in Training Resources and all the work that you folks are doing in the Iowa Gambling Treatment Program and the opportunity to be here to speak to you about spirituality and mental health from a clinical perspective. I went over the talks that you're seeing over the next couple weeks, and here's my main slide for the talk. And I see a lot of them are, firstly, this is great, just a great series that you're doing, and I'm really honored to be a part of it and to be kicking it off. I think the other talks, if I'm understanding correctly based on the descriptions, are really very specific to problem gambling. And I'm going to have a fair amount of material specific to gambling, but really this is a broad talk, and I think it's appropriate to start the 6-part series with some more broad overview comments about an area that doesn't get addressed enough in clinical treatment, and as I'm hoping I will convince you today, is clinically relevant to many individuals in general and many individuals who cope with gambling in particular. I also wanted to thank Eric Prost and Katie B for inviting me for this opportunity. I was very eager to participate when Erin contacted me. And I'd love to visit Iowa at some point. It's been 10 years since I was there, and I just had a stopover in the airport. But I'm grateful today to be participating from Boston. Okay, so we'll talk about this in a couple of minutes. The mental health disciplines in general and psychiatry in particular, they've had a tenuous history when it comes to dealing with spirituality, and a lot of practitioners, they shy away from the subject, but not the individuals on the screen in front of you. I'm very grateful to a number of individuals, and I won't name them all by name, but I will mention my graduate school mentor, Kenneth Pargament. Some of you might be familiar with his work, and really a leader in the field and a wonderful person, frankly, and also my funding support which is at the bottom of the screen. I'm very grateful to them, eternally grateful, in fact, for enabling me to continue to do the work that I do. To introduce this subject, I'm going to talk to you about a recent case that I assisted with as a consultant. And of course, all the patients described here, this is, firstly, I have informed consent to share the material, but I've changed names. None of the images are really images of their patients. Of course, I'm protecting their privacy and confidentiality. But let's talk about a patient, we'll call her Elizabeth Carmen. She was a 27-year-old Roman Catholic lady, and she presented for outpatient care, had a major depressive episode with some severe panic attacks, and all of that happened in the context of a very significant psychosocial stressor, specifically her husband. She had been married for 3 years, and he had relapsed. She knew that he had a gambling problem prior to their wedding, but he relapsed with his gambling disorder recently without her knowledge, and it got very bad, and the family home was now up for foreclosure, and she had a very significant worsening of her symptoms. And she's contemplating, well, what do I do? Maybe this marriage isn't going to work out, and she feels religiously conflicted about that given her Roman Catholic background, but she doesn't want to discuss her faith at all with her secular, ostensibly secular anyway, psychiatric team, because she had concerns that those religious issues that she's facing are just going to be dismissed or maybe even viewed as pathological. So that was one case. Here's another case I dealt with. We'll call him Michael Santos. He's a 51-year-old Latino man, a devoutly religious man. He was struggling with a gambling disorder, and primarily as a way of coping with anxiety and depression. It was really very emotion regulation function for him, his gambling. He realized that gambling helped to ease his tensions, and he felt unnerved, he felt hopeless, and then gambling gave him a sense of, chasing losses. I'm gonna win. And also, it took him out of his cycles of anxious thinking. So what ended up happening, since he was being motivated by those depressogenic, anxiolytic thinking, he ended up with a lot of poor decision-making, losing money, chasing losses, as I mentioned, increased tension, increased depression, more gambling, higher accrual of debt, and you can only imagine where this landed him up. I think it was $50,000 or $60,000 in credit card debt by the time he came in. And when he realized he had a problem, the first person he reached out to was his priest, who responsibly referred him for psychotherapy. And he wants to address his spirituality because he thinks it's important. He thought it was important to him as a resource in order to help him deal with his anxiety and his depression. But his therapist had not even inquired about it, except for 1 or 2 questions. Is there a religion you affiliate with? And I think that was about it. Is it important in your life? And that was the end of the discussion. And they had been working together for over a month. And these are just 2 cases. There are countless others where mental health practitioners have, I would call it a conundrum. The conundrum is this: we have years of education and years of clinical experience, but the overwhelming majority of us lack even the most basic training in how to address spirituality and religion when it comes to our patients and dealing with them clinically. When it comes to gambling disorder in particular, but really any other area of psychiatric functioning for that matter, we're not well prepared. The majority of us, not all, but the majority of us, a vast majority, are ill prepared to handle the intersection of spirituality and mental health. And this is not an inconsequential concern or a problem, a small problem, because if you look anywhere in the United States of America, it doesn't take much to see that spirituality and religion are very powerful forces. They shape economics. They shape our social behavior. I hate to say it, but they shape politics. And no, we are not getting into that subject. But they shape our lives. And to quantify what that means, these are some fairly recent statistics from national polls. I'll let you get acquainted with that. But basically, the vast majority of Americans have some belief in God, even certain belief in God. 3/4 of Americans have certain belief, 100% belief that there's a God in heaven. Furthermore, if you can look down the rest of the slide to see the numbers there. 3/4 of Americans identify as having a Christian faith. 57% believe that religion can solve all or most of today's problems. I like to tell practitioners when I mention that last fact, it doesn't matter what you believe. What matters is that the patients who are coming to you have that, many of them anyway, have that as a part of their world system, and therefore it's important to address this domain. Here's another one. 61% of Americans support daily prayer in the classroom. Now, whether or not you agree with that doesn't matter. What does matter is that many of your patients feel that this is an important part of their lives and a part that needs to be addressed. And that's my only point here. On a global scale, it's even more common. In fact, this is a world map, of course, and shows the importance of religion. You can see that the United States is not the most religious country on planet Earth. In fact, I think it's even less than average. If you compare it to Brazil or certainly areas within the Middle East, we're pretty secular, not compared to Northern Europe. But in any event, on global trends, this slide will quantify some of those. This is the Pew Forum, which did an amazing study back in, it was published in 2012. Out of the entire world population, you're looking at 5.8 billion religiously affiliated adults and children. That's 83% of all human life. And if you take out China from the mix, because the 700 million or so religiously unaffiliated individuals live in China, it's actually 87% of the world, except for China, has a religious affiliation, interestingly enough. So it's not only a matter of prevalence, though. Many patients, and maybe it's because it's so prevalent, many patients who come to us for help with mental health concerns, they want to address spirituality and religion in the context of their psychotherapy. Here's some more data. The second line on that, the second row on in the table in front of you is a study that we did at McLean Hospital. 58.2% of our patients, which was about twice as many as I expected, had fairly, moderately, or very strong interest in having spirituality as a part of their mental health. What was interesting is I started presenting that result to my colleagues in the department, and they said, well, maybe it's more the psychotic patients who want to talk about this, or maybe it's the hypomanic patients, or maybe it's the scrupulous patients who have OCD. So I said, you know what? I don't think so, but I don't know. Let me test. And I did. I looked at those clinical factors, and I looked at all sorts of demographic factors, including geriatric age. I thought individuals who are older would want to have more spirituality as a part of their care. We looked at race. We thought individuals who were not Caucasian would want to have more of a spirituality as a part of their care. There are empirical reasons for that. We thought that education might be associated. We thought that individuals with a college degree would be less likely to want to have spirituality as a part of their treatment. We looked at homelessness and previous hospitalizations. We thought maybe intensity of symptoms and dysfunction in a person's life would be associated with greater interest, and none of those factors panned out. None of the clinical factors and none of the demographic factors across the board. Whether people were millennials and 19-year-old college students in Massachusetts, or 65 years plus and coping with bipolar episode, didn't matter. Individuals wanted to have, a significant percentage of them wanted to have spirituality as a part of their treatment. With one exception, current depression was associated with greater interest. Patients who were currently depressed were more likely to want to have spirituality as a part of their treatment. I can think of some potential reasons for that. Maybe they wanted to have more hope. Maybe they were seeking connection in a spiritual domain. Maybe they were looking for more meaning and purpose. There are potentially some reasons, I don't know, all of that's conjecture, but it doesn't really matter. What matters is that a very substantial number of our patients, and this is in Eastern Massachusetts, which I like to quip is not exactly a hotbed of religious fundamentalism within the country. In any event, another interesting thing here, I'll just go on about the study, is that many patients wanted to have spirituality as part of their treatment, but had no religious affiliation. In fact, 37% of patients who were not affiliated with a religious group still had a fairly moderately or very strong interest in speaking to their treatment team about their spirituality. And conversely, there were a lot of affiliated patients, in fact, 42%, which is very substantial, who did not want to have spirituality as a part of their treatment. So on the whole, what we're finding is that the classic question that we ask to patients in mental health is there a religion you affiliate with? And it turns out that that's not the right question to ask because it's not relevant to treatment. A good question to ask is, do you want to address this with me? And there will be more on clinical intervention towards the end of our talk today, but that's just a preview of coming interactions. I'll let you read the rest of the slide, but basically, individuals are much more likely to go to clergy than they are to us as mental health practitioners. And people in general want to have this as a part of their care. Okay, I'll move on. Okay. However, among psychiatrists, and this does apply perhaps to a somewhat lesser extent, but still, nevertheless, to other mental health practitioners. This is a study by Farr Curlin at the University of Chicago, a stratified national sample of 2,000 psychiatrists within in the United States, a 2007 paper published in the American Journal of Psychiatry. And this is how individuals in the field interpret religion and spirituality and mental health and how they interface with the subject. The results are not great. At least 1 in 10 to 1 in 5 psychiatrists have attitudes and practices that do not bode well for the provision of spiritually sensitive care with patients. Now, that occurs in a context, a historical context. Now, there's no one more notable than Sigmund Freud for his anti-religious views. These are 2 known excerpts from his writings. The first is from Future of an Illusion. He said very clearly and explicitly, religion is comparable to a childhood neurosis, which can't be more clear than that. Here's another one from Civilization and its Discontents, a 1931 book that he wrote. A little less famous, but nevertheless significant. He writes, the whole thing is so patently, referring to religion, the whole thing is so patently infantile, so foreign to reality, that to anyone with a friendly attitude to humanity, it is painful to think that the majority of mortals will never be able to rise above this view of life. It is still more humiliating to discover how a large number of people living today who cannot but see that this religion is not tenable, nevertheless, try to defend it piece by piece in a series of pitiful rearguard actions. So as I like to respond, ouch. Now, I want to contrast that. Well, actually, I'll tell you one more story. Over time, these sentiments have shifted. We don't find such a level of outright antagonism, inflammatory antagonism towards religion or spirituality anymore. But what we do find is the concept that religion and spirituality should be checked at the door of the therapy room and not cross over the threshold. Literally an hour ago, I just interviewed a candidate for a fellowship program in my New York office. And the individual said to me, I understand that you do work on spirituality and mental health. Is that the kind of training that I would get? I would like to get it. And I said, it's definitely a part of our training program, and thank you very much for your interest. And he then said, you know, I really have no clue what to do. In fact, I was taught that if the subject of spirituality and religion comes up, you should change the subject. And I don't know, it was, I was, in my training, I was indicated to me that that's what I should do, but it was never told so explicitly to me, and I thought it was a sort of an interesting reaction. I will tell you another story, though. I was on interview for a clinical placement in Canada several years ago, and the interview was going very well. It was for a cognitive behavior therapy clinic, and I was very excited to be able to take this opportunity to learn about it. And at one point during the interview, the head of the clinic said to me, I know that you're doing research on spirituality and mental health. If you were to come here and be a trainee in our office, you wouldn't speak to any of our patients about that subject, would you? So I didn't know what to say. I didn't want to blow the interview or the opportunity. So I said to them the only thing that I thought was reasonable at the time, which was, if you have a policy not to speak to patients about spirituality, then I will abide by it. I'm coming here for an experience in cognitive behavior therapy, and you know, I'll follow the rules of the clinic. And I did go to that clinic, and I did get a great training experience, and I'm very glad I went. But I remember there were at least 3 patients during my training period there who wanted to speak to me about their faith, and I changed the subject as I was instructed to do, basically, and it was not to their benefit. It was to their detriment. I don't think that we provided the best care because of that policy in place of not attending to their spirituality and their religion. And I will contrast that with my current position at McLean, where I feel not only welcomed, but valued because of being able to develop and given opportunities to develop a dialogue and a discussion and trainings and how to help patients, clinicians rather, address patient spiritual and religious issues in the context of care. So nice to be here. Okay, now before we go any further, I often get the question, what is spirituality and what is religion and what are you talking about anyway? So that's a fair question, and I wanted to address that before going on to anything else, so we're all clear. Now, spirituality involves any way at all of relating to that which is seen to be sacred. Sacred literally means set apart, and the idea is sanctified, holy, or consecrated, something that is special or set apart from the physical world. So we are talking about the metaphysical here, something that is greater than just a set of atoms. Now, spirituality, that perception of the sacred, of something that is sanctified and holy and consecrated and above nature, that might be linked to an established institution, or it might not be. It could be traditional, or it could be something which is more, let's call it New Age. Religion, on the other hand, that's a specific term, and that refers to institutionalized or culture-bound ways of defining the sacred and relating to it. So when a group of people have an institution or a culture around defining the sacred, defining what is metaphysical, and relating to it either with rituals or with beliefs, and that group of people collectively hold of those beliefs and practice those rituals, that would be a religion, which is a subset of spirituality. So if we're going to put it on a Venn diagram, then this is what it would look like. We would have spirituality as a larger construct and religion as a subset of that. Now, I tend in my writings and my talks, and I will do this for the rest of our time today, to conflate spirituality and religion and to speak about them as a single unitary construct. Now, I recognize that spirituality is non-religious for many people. And I recognize that they are theoretically disparate, as I just shared. But they are closely theoretically linked. And empirically, though, they are very closely overlapped and linked. The concordance rate, if you will, between spirituality and religion is about 63 to 85%. And what that means is that somewhere between 2/3 and 85% of the population is either spiritual and religious, or not spiritual and not religious. Yes, there is a growing group of people who are spiritual but not religious, but they at this point are the minority, at least in the United States, less so in Northern Europe, I'll add. And in the interest of parsimony, I don't want to be, I think it's more clinically appropriate to weave in and out and speak about spirituality, religion as a single construct. In fact, a lot of the time I'll just refer to S/R, which means spirituality / religion. And please pardon the inaccuracy, any inaccuracy around that. Okay. Now, how is spirituality / religion relevant to mental health? I want to speak about this based on current theory and current research. So, the current literature has then identified 4 primary ways or effects that spirituality has on mental health. The first is that spirituality and religion can shape the clinical presentation of symptoms. In some cases, spirituality can co-opt emotional distress, and the core features of psychopathology will take on prominent spiritual or religious themes. The classic example of this is religiously or morally themed psychosis, where people take on, let's say, a delusional identity of grandeur with the identity of a religious figure, such as a prophet of the Bible. Sometimes in obsessive compulsive disorder, we have morally themed scrupulosity, where people are overly concerned about issues related to religion and engage in religious rituals in order to cope with those obsessions. We have hyper-religiosity in mania and hypomania, where individuals are revved up and hyped, excited, and experiencing manic symptoms, and those are expressed with religious fervor, with religious activation. Once in a while, those are the three main ones: mania, psychosis, and obsessive compulsive disorder, not in that order. Another one that can come up is eating disorders. Sometimes people are restricting their eating and they have religious themes to it. There's some other disorders as well. Now, but I think you understand what I'm referring to here. Many people in mental health believe that this is the primary way that spirituality affects mental health, because it's so obvious when it happens and you can't ignore it. But the current research and theory is interesting on this, because it suggests that religious involvement is not associated with greater incidence, greater severity, greater prevalence of any psychiatric disorder, and definitely not psychosis, OCD, anxiety disorders in general, or mania. So what is this domain then? The effects are that spiritual symptoms occur when individuals from a religious or a spiritual background or culture have those forms of psychopathology. Their symptoms are likely to take on a spiritual or religious theme. The symptoms will attach themselves to those areas of the person's life that are meaningful, and for such individuals who have spirituality or religion as a orienting framework in their life, that's what it will attach onto. I like to tell my patients who have religious OCD or religious psychosis, if you weren't religious, you would still have OCD or psychosis. You'd just be obsessed or delusional about something else. It wouldn't be religion. And that does seem to be what the literature points to. With that said, people who have religious symptoms or spiritual symptoms, they fare worse than people who have non-spiritual symptoms. And I think there are two reasons. One, primarily, clinicians don't know how to deal with this. They struggle to delineate, where does bona fide spirituality end and psychosis or obsessionality or hypomania begin? And for example, is that heartfelt prayer or is it psychosis? Is that spiritual striving, or is the person engaged in hyper-religiosity? Does that person have a genuine sanctioned religious practice, or is that hand-washing excessive and actually a compulsion that I'm witnessing here? And people don't know how to delineate those lines because we're not as familiar with religion for a bunch of historical reasons that we spoke about before. Another issue, though, is that patients can lack insight. They can lack motivation to make these distinctions. For an individual, for example, with obsessive compulsive disorder centered around religion, they're not only facing the possibility that they might harm themselves or harm somebody else, as is common with OCD, they're facing the possibility of an irreversible hell forever. And that's a very scary thought. So there are some of those aspects as well. But bottom line is that spirituality can affect symptom presentation, and when it does, though, what we're really seeing is a specific form of symptom with its pluses and minuses, if you will, and an area for intervention. Okay. Now, a second effect that spirituality can have on mental health is that it can protect. It can protect against mental distress. Now, this is enough of a topic to literally fill a whole day, but I'm hopefully going to do it in less than 5 minutes. To summarize, in the general population, there have been well over, actually recently there was a review of about 1,000 studies, and 80% of those studies demonstrated a positive effect, generally speaking, positive relationships between spiritual beliefs, spiritual practices, and greater life satisfaction. And about 2/3 of the studies showed a protective effect, a buffering effect, or association rather, with less anxiety and less distress. More specifically, spirituality and religion is associated with much lower rates of suicide. The odds ratios are actually less than 50% for individuals who have versus do not have a religious affiliation, which is very significant. And also substantially less substance abuse. Substance abuse, we have very consistent findings, cross-culturally in fact, 20% reduced risk at least for substance abuse among people who have spirituality as a part of their life. And we also have a protective effect against depression, by and large. A small effect, and borderline clinically significant, that small, but nevertheless a consistent effect in the general population. Let's talk about gambling for a second. There's a study in 2016 in the Journal of Gambling Studies, and the title of the study was Religious Background in Gambling Among Young Adults in the United States. And they reported that individuals who attended services weekly had 20% lower odds of ever having gambled, and people who had a Protestant affiliation, either mainline or conservative, had between 20 and 40% lower odds of ever having gambled. But we're going to come back to that study. There are very few studies on spirituality and gambling, but we're going to come back to that later on in the presentation, hopefully. Now, why might spirituality protect against mental concerns? I'll just give you a bit of theory here. Well, it does depend on the mental health concern, but when it comes to addictions, let's talk about gambling and why it might help, or why it might serve a protective effect. There's growing evidence that spiritual religious beliefs and practices, they habituate individuals to delayed gratification and reward. Here you have a picture of a young woman who is not diving into her dessert. She is savoring it, seemingly with a spiritual glow, and appreciating it and delaying the gratification and the immediate reward of having her taste buds soak in the delicious sugar on the end of that spoon or fork or whatever she's got, and taking a moment to pause. Now, there is a recent review paper by Michael McCullough at the University of Miami and one of his graduate students, and he suggested boldly that all observed effects that we see between religion and greater physical health, and there is a literature about this, which is beyond the scope of our talk today, but we're talking about lower blood pressure, better cardiovascular functioning, better recovery from illness, increased longevity in general. He accounts for all of those effects in this paper by the fact that spirituality and religion is associated with a tendency to override emotional responses that are natural. In other words, people can take a moment and pause and engage in something which is not driven by their raw emotion and just the way that they feel or the way that they think or the way that they've been habituated to behave. In English, engaging in regular spirituality and religion seems to enhance self-control, and by increasing faithfulness and fidelity to a valued set of standards. Irrespective of the religion, and again, whether you agree with it or not, people are being faithful to a set of standards, to a set of practices, and to a set of beliefs, even when the immediate or the fixed rewards are not present. In turn, this has a lot of mental benefits and physical health benefits, and I guess supposedly some spiritual benefits, although that's definitely beyond the scope of our talk today. I can give you clinical examples of this, but needless to say, people who have a regular engagement in rituals or beliefs that they hold in their minds, even and holding on to faith or hope, even when the immediate evidence around them is not good and suggests that things are not going well, that can help people manage their symptoms more regularly when they're symptomatic. It can prevent the onset of symptoms and result in optimistic long-term prognosis and ultimately more self-control. And that could be a couple of theoretical ideas why we see protective effects in general. One more positive thing, and don't worry, we will speak about the negative side of spirituality. This isn't, it's not all fun and games. But one more positive thing is that spirituality and religion are often associated with coping and part of the coping process. Many people engage in religious coping, which is drawing upon religion to cope with distress, with negative life events. A lot of different ways people do this. Excuse me. People can have cognitive appraisals, benevolent religious appraisals. I've heard cancer patients say this, that I don't know why this is happening, but it's God's will. It's part of a greater plan and it's greater than me. That's a benevolent appraisal of a very trying situation, which is informed by religion. Another one is active religious surrender, also among cancer patients. I'm going to do my best, but at the end of the day, it's up to God whether this works or not. Seeking spiritual support, such as reaching out to clergy, reaching out to people in a faith community. trying to increase a spiritual connection with people or with our faith in order to cope with distress. These are different forms of religious coping, and this is very common and very well researched. We're talking about more than 5,000 empirical studies have been done, including meta-analyses on the effects of religious coping. And in many cases, the effects are significant even after you control for secular forms of coping. It's also very common. After September 11th, 2001, 90% of a representative sample drawn from across the United States reported turning to religion in some way in order to cope with the events of that day. That's just one example. Now, many of the effects of religious coping can be explained with the cognitive model, which I'm sure many of you are familiar with. The cognitive model put forth by Aaron Beck and colleagues is that human beings have core beliefs, and those beliefs are about three things: ourselves, they're about the world, they're about the future. That's what we have beliefs about. And in any given situation that occurs, those beliefs will engender situation-specific automatic thoughts, thoughts that are relevant to that situation, interpretations, ways of thinking, and those thoughts directly lead to and are the cause of, in terms of the model, our affect, our mood, our emotion. There are myriad examples of this, but the idea is that when a patient engages, as relevant to our topic, if someone engages in a benevolent religious appraisal and says, you know what, it's a bad situation, but it's part of God's plan. They see a stressful situation as part of a larger rhyme and reason in the universe. That belief can change and can engender positive, adaptive, situation-specific automatic thoughts and lead to better emotional outcomes. Right. Okay. Similarly, when people have active religious surrender, they draw on the belief that they're going to do whatever they can, but at the end of the day, they're going to give it up to something which is greater than them. That can be similarly helpful. I'll give you an example. I had a patient who had major depression, and that was in the context of breast cancer. And she persists. She has a very rigorous treatment program, and on a daily basis, she cites this prayer, the Serenity Prayer, which is on your screen. Which is a very popular prayer from Alcoholics Anonymous, and she does it every day to strengthen her belief that ultimately she's going to do whichever she can, but ultimately it's not in her hands. And it's a cognitive strategy. She's changing her thoughts when she engages in this prayer in order to fortify herself. So when her medical team gives her news, whether it's good or hopefully not so bad, she can remain at least psychologically functional and weather those storms. By the way, these two belief-based cognitive strategies that we're talking about, the first one being benevolent religious appraisals and the second one, active religious surrender, they're linked to better psychosocial adjustment and quality of life in the context of numerous life stressors. However, just as anything in life can be good and bad, so too spirituality can be very negative as well as positive, and it's very important to address this and to understand it. Spirituality can exacerbate distress. It can cause struggles and distress. Spiritual struggles involve religious or spiritual beliefs or practices that exacerbate or play an ideological, functional role in the development of emotional distress. There are a lot of different forms. Sometimes spirituality can induce guilt. It can induce shame. People can have family conflicts over spiritual issues. People can have beliefs that God is disregarding them, that God is out to get them. Just last night, I had a session with a young woman who said, God hates me, and he's malevolent, and there's nothing I can do, and he's playing games with me. Needless to say, she's struggling with her emotions. Empirically speaking, these forms of struggle and other forms of struggle, they occur less frequently than the positive aspects of religion, so they're less statistically frequent. But when they do occur, the effects are extremely problematic, large, clinically significant effects on a large, wide array host of psychological problems. Just to take you through a couple of the types of spiritual struggles. There are really three types identified in the literature. The first are intrapersonal spiritual struggles, intrapersonal being within a person's self. In a nutshell, a lot of people start to look at themselves inside at some point in their life using a spiritual lens or otherwise, but particular to our topic, a spiritual lens, and they don't like what they see. They're grappling with that. There are a lot of different forms of this, but it's an intrapersonal rather, wrestling with our identity. What's our purpose in life? Am I achieving my purpose in life? Religious guilt, having shame for having sinned or engaged in some sort of problematic behavior, having hopelessness about spiritual development, doubting our spiritual potential, or fatalistic beliefs that undermine our efforts, existential views that the life is inherently meaningless. There's a whole host of these. I want to highlight something. Remember that study we talked about before? It was entitled Religious Backgrounds and Gambling Among Young Adults in the United States. Well, look at this. This is very interesting. The researchers found that among people who do gamble, religious attendance was associated with 2 to 3 times as much gambling, a gambling disorder. So for people who as we learned before, religious affiliation was associated with substantially less gambling. But if people do gamble and they have a religious affiliation and attendance, they're much more likely, 2 to 3 times as likely to have a gambling disorder, much more likely to chase losses, more likely to have relational problems, more likely to gamble in order to cope with emotions. And I wonder whether these intrapersonal spiritual struggles can account for these findings. Some of you probably will know this better than I, being in the field dealing with these patients day to day. It could be that when religious individuals gamble, they feel excessive shame and guilt, and that in turn can serve as a ripe context for the development of a gambling disorder. Because instead of just using gambling as a form of entertainment, which is what it's supposed to be for at best, then they're using it in order to deal with their emotions. And as a result, they might end up in trouble. I'll give you some other examples, though. Another one is interpersonal. We were talking about 3 types of spiritual struggle. The first is intrapersonal. Second is interpersonal. This involves social and relationship issues that carry spiritual themes. Excuse me. The most common example here is disagreements with clergy and altercations with others in the spiritual community, but it can also be patients. It can also be within families as well. One of my patients put it this way. She said, "I really don't like fighting with people in my work, but I can't stand fighting with people in my church. It not only does that sever my horizontal relationships, because it also severs my vertical relationships as well." I thought that was beautifully put. Another one is witnessing wrongdoings done by religious individuals. This latter struggle is very problematic. It has a lot of staying power in people's memories. People think about it a lot for years to come. At McLean, we do spirit groups, spiritually based treatment groups, which I'll tell you about later, for our patients. And it's been nearly a decade since the Boston Globe did its expose on sexual abuse of minors within the Archdiocese. But almost every week, that theme comes up in our group sessions. At least one patient will bring it up of the hundreds being treated. The third form of spiritual struggle are divine spiritual struggles, and those directly involve the realm of faith. The most pervasive of these, most common, is the question of theodicy, the old question, why do bad things happen to good people? And it's a good question, and no, I will not answer it for you here today, not that I could. But the other issues also are, is God punishing me? Is God unjust? Is God malevolent? Is God out to get me or playing with me, as my patient put it yesterday? These beliefs can taint day-to-day thinking and lead to the interpretation of events in a negative, maladaptive light, and also lead to bad decision-making and poor behaviors. People who have a punishing God appraisal, that can engender stigma, it can engender shame, that somebody's falling short in their spiritual practice. It can lead to disengagement from, firstly, spirituality, secondly, from communities, thirdly, from other day-to-day activities, and really functionally lead to the onset of depression, anxiety, and other concerns as well. But irrespective of which one of these 3 spiritual struggles people have, whether it's intrapersonal, interpersonal, or divine spiritual struggles, or a combination of the 3, they are a significant risk factor for psychopathology and basically potentially toxic. I'll give you some stats. This is a study I did with some psychotic patients back in 2013 at McLean. As you can see, spiritual struggles were associated with significantly greater suicidal ideation. They were also associated with greater anxiety and depression, but the suicidal piece was very high. We were able to account for 46.2% of the variance in suicidality through a very small measure of negative religious coping, or spiritual struggle, that is. That's an R-squared value, not an R value for any researchers in the audience. A very high percentage of variance. However, interesting to know, positive religious coping, the use of religion to cope with distress in a positive way, that was associated with greater improvements in depression, greater improvements in anxiety, and greater improvements in well-being, with a large effect size over the course of treatment. So interestingly, even though spiritual struggles were part of the problem, or maybe because spiritual struggles were part of the problem, and for many patients, although not all, it seems that engagement in positive spirituality could be part of the solution. Okay, I'm gonna skip this. Let's just briefly review and recap what we've learned so far about spirituality and mental health before going on to the next part of the talk. Essentially, I've made 4 points. Number 1, spirituality and religion are very common in the general population. They're more common than they are not common. Number 2, this domain is subjectively important to many individuals. The majority of psychotherapy patients presenting for treatment, they want to address spiritual issues with their clinicians, and that goes even here in Eastern Massachusetts. Number 3, for historical reasons, mental health practitioners, we tend to shy away from the subject, and we don't assess for this, we don't address it, and I don't think we're doing our patients a service by that. And number 4 is that it's really too bad, because spirituality and religion, they're related to mental health in many ways, both positive and negative. Okay, so you are all clinicians and you see lots of patients. So what can we do about this? Well, I'm going to tell you what I'm doing about it first. In 2015, McLean received very generous philanthropic support to start a spirituality and mental health program. And it's a multifaceted initiative involving research and clinical innovation and education, such as today's webinar, in order to provide spiritual integrated care en masse. I want to tell you about the spiritually integrated psychotherapy that we are doing. Spiritually integrated psychotherapy, it's similar to conventional treatments. In fact, it is a conventional treatment, except that it hypercharges or changes by drawing on spiritual and religious resources in treatment and addressing spiritual issues. In other words, it's spiritually sensitive treatment. These are mental health treatments. Spiritually integrated psychotherapy is not pastoral counseling. Pastoral counseling is provided by clergy, and it is one of the goals of pastoral counseling is spiritual change, or helping people to become more spiritual. That's not what spiritual integrated psychotherapy does. People might become more spiritual in the process, but that's not the goal. The goal is to help them with a mental health concern and to utilize or harness spirituality in the course of treatment, just as we would utilize any other domain in the course of treatment if it were clinically indicated for a patient. To date, over 50 randomized controlled trials have been done of specifically spiritually integrated versus non-spiritually integrated treatment. The results seem to indicate that there are not specific advantages for integrating spirituality into treatment, for the majority of problems, that is. However, such approaches are just as effective and often more desirable to patients, and there is greater engagement by patients in the therapy process, and we will talk about that more at the end. And it can be done for a host of problems, including social anxiety, physical and psychological well-being among cancer patients, migraine headaches, even there has been some research, and a whole bunch of other things, especially anxiety and depression, of course, are usual subjects. Oh, and of course, addictions, including behavioral addictions. Now, let's go. Okay. I want to tell you about a hospital-wide protocol that we have, which guides clinicians in how to have an initial discussion with patients, individual patients, on about spirituality and about religious matters. This is, I hope, will be helpful to you in learning how to speak to your patients about this matter, because a lot of clinicians just don't know what to do. Here's an overview of the approach, and we'll go through each step methodically. Basically, there are only 2 steps. The first is an orientation, which includes informed consent. And the second is what we call a functional assessment. For those of you who have training in cognitive behavior therapy, and behavior therapy in particular, you'll know more about a functional assessment, but I will explain what it is. In a nutshell, it's learning or discussing with the patient how X is related to their symptoms. X in this case being spirituality. How is their spirituality related to their symptoms? And there are usually 3 ways that we can parse it out with any given patient. Sometimes it's multiple ones of the 3. Either it's positive or it's negative, spiritual struggles, or they're having spiritual symptoms. And you are familiar with all of that because, well, we have been speaking about it for the last little while. So I'm going to take you through the actual way of doing this. Now, in orientation, the first step in talking to patients, and I'll say this does not have to be done during the first session. I think it should be done within the first 3 sessions with any given patient, unless they're particularly acute and they need a higher level of care, or they are a danger to themselves or others. But this is a topic that I would say is a moderate priority and something that should be discussed at least somewhat at the, let's call it, outset of treatment within the first couple of sessions. So an opening question here, I have 4 of them, sample questions at the bottom. One of them might be, would you mind if I asked you about your spirituality and religion? Most patients will say, not at all. Some patients will say, well, why do you want to talk to me about that? And then a follow-up would be, well, this is a domain that's relevant to a lot of people's care, and it's something that I like to ask people about. If you don't want to talk about it, we don't have to, but I have some questions for you. And they'll usually say, okay. I don't think I've ever had a patient flat out say no, maybe 1 or 2. But that's in, I don't know, 1,000 patients we've consulted with in the last couple of years. The purpose of the orientation and the informed consent is a couple-fold. 1, to open the topic for discussion. To have them, the patient, open to discuss this topic, and to open it with them and to give them an overture that you want to discuss it with them, or going to give them the opportunity to discuss it in treatment. A second thing is to obtain informed consent. Patients might refuse, and it's important to give them the opportunity to do so. A third thing, though, is desensitization. I had a patient, I got to tell you this story. A couple years ago, there's a young lady who came to see me in my New York office, and I said, will you mind if I speak to you about your spirituality? And she looked at me like I was from Mars, and she said, I've been in psychotherapy for 10 years, and no therapist has ever asked me about my spirituality. Like, really? You want to speak to me about that? And I said, yeah, like, why not? So she smiled ear to ear, and she said, wow, you mean I could speak about God in here? That's a whole new level in my therapy. So it was just such a great anecdote. But bottom line is patients sometimes need to be desensitized to it, especially people who have had previous treatment, because there's this whole culture, as we were speaking about before in mental health, of ignoring spirituality. So if a clinician's going to go and talk to them about it, they sometimes need a minute to gather themselves. And now, also, some patients might shy away from the subject. They might think that they're going to be judged about it, or they're going to be criticized. Those are some of the cases that I mentioned at the beginning of our talk today. The primary job of the therapist here is just to put the patient at ease. And this is not a long process. Hey, do you want to speak about your spirituality as a part of your life? Do you want to talk about it? Yes or no? No problem. No pressure at all. And the orientation should facilitate this goal. Now, if the conversation takes off, you can delve more deeply into it with follow-up questions. Is it always in your life? Has it always been that way? What are some of your beliefs? What are some of your practices? Is there a community that you associate with? And just getting them chatting about it, frankly, to have an initial conversation, which is not a clinical conversation, except that it gets the patient engaged in the process of the discussion. I guess there are some clinical aspects of it because you're gathering initial information about the patient's spirituality, which then could have a clinical function later. But that's not the primary piece. The second, though, is really the core and the cornerstone of the approach. This involves sparking a discussion with a patient about how spirituality is relevant, clinically relevant to their symptoms and to their treatment. There has been a fair amount written in spirituality and mental health literature on how to do spiritual assessments. Almost invariably, it ends up doing a spiritual history. I do not see the clinical benefits of doing a spiritual history in the current era, especially in the era of managed care. We are pressured to see patients. We are pressured to have results. And I think it's important to have quick, focused treatments and assessment procedures that keep our eye on the ball of treatment. And therefore, at the hospital anyway, this is what we encourage our clinicians to do, and I'm going to encourage you as well, which is to ask the following question, which is, how is your spirituality and religion as a patient related to your symptoms and your treatment? How is it related to your symptoms? How is it related to your treatment? Is it something that helps you to cope? Does it exacerbate your symptoms? Does it fluctuate when your symptoms go up, when your symptoms go down? How does it relate to your life? This is a central question. An alternative question could be, is it relevant in any way to the problem that you're seeking help for? You're seeing problem gamblers. Is your spirituality relevant to your gambling in any way? Often patients will sit and think and pause and be, that's a really interesting question. Let me think about it. And then come up with something really remarkable that typically maps onto what we were speaking about before. I'll just flip back a couple slides. Typically, they will say, just use this feature over here. Oops, sorry about that. Hold on. Oh, well, I don't know if you can see my cursor, but I'll either say that it's positive, or that it's negative, or that they're having spiritual symptoms, or a combination of the three. It could also be related to associated symptoms, such as anxiety or depression. Sometimes people are engaging in gambling in order to deal with another set of symptoms, or a relationship problem. Maybe that has a spiritual theme to it. The goal of the question, though, is to focus the discussion on the treatment process. In other words, the topic of spirituality and religion warrants inclusion into the treatments that we provide as mental health practitioners, only in as much as it's clinically indicated and relevant to the presenting problems and the treatments that we're providing. The clinical focus is important because it conveys to patients that, yes, spirituality is an important part of your life potentially. It's an area that's potentially worthy of exploration, and it could be personally significant to you. But I'm more interested in how it's relevant to the treatments that we're going to be doing together as a group. Yes. Now, some other points here. There's another piece here, which is that psychoeducation is a huge part of spirituality and mental health intervention, because a lot of patients have never had the opportunity before to be educated in how spirituality is related to mental health in general, or to think about how their spirituality is relevant to their symptoms in particular. So this is part of the functional assessment process. It's not uncommon for patients to struggle a little bit in thinking about how their symptoms are functionally relevant to how their spirituality is functionally relevant to their symptoms. Lots of patients are not used to thinking in these terms, and in many cases, this is a teaching moment to help for clinicians to help patients to start to think about what impacts my emotions in general, and how does that impact my likelihood to engage in, for your purposes, gambling or whatever problem behavior, and my likelihood to have issues in my life or otherwise. So it can be a prompt in a good context in order to just deliver very well-designed care. Just an example, when patients seem completely unaware of how their spirituality might relate to their mental health, you could convey that for many people, spirituality is a psychological resource. For some people, it's an area of struggle. Some people have spiritual symptoms. Do any of those seem to apply? A patient might say no, no, and no, in which case the intervention's over and you can go on your merry way. But in other cases, they can identify it, either with some prompting or otherwise. and they can understand how their spirituality is relevant to their symptoms and their mental health. And then exploring the full relevance can really create a number of potential intervention points to help the patient move along in treatment. I mentioned previously, a functional assessment, it can lead to discussion in a couple of topics. First, a lot of patients report that spirituality is an important resource and it helps them. Some of these patients will say that spiritual beliefs give them solace. For example, they have the idea that they're never alone, or they have the idea that nothing's impossible, or that they can only control the process in life, they can't control the outcome. They can only focus on what they need to do, but the greater outcomes in their life are really not in their control, and accepting that. They can think about the idea that everything happens for a reason. A lot of patients come in with these beliefs, or the idea that nothing's permanent. A lot of patients also have engagement that they do, regular prayer, and different forms of prayer, whether it's gratitude prayer, or request prayer, or praise, or silent prayer and meditation. People have spiritual coping and spiritual coping statements that they make, such as let go and let God, very common one. The serenity prayer is another one. Everything happens for a reason. That's both a belief and a statement that people make. Seeking religious support. When people go to their clergy, how does that impact their mental health? Does it give them a sense of meaning, a renewed sense of commitment? Is it something that reacquaints them with their spirituality or reconnects them with their family? Or is it something that creates, well, we'll talk about spiritual struggles soon. Reading spiritual texts, practicing forgiveness or engaging in gratitude exercises. These are lots of different ways that patients in a functional assessment could give examples, I think rich and potentially clinically useful examples of how they utilize spirituality in positive ways in their life in order to do well. Just one anecdote here. I recently had a consultation with somebody, his name, we'll call him John, who was at a private, one of our private programs at McLean. He was the CEO of a large company, and for 30 years, he lived a very active lifestyle. He was on the squash court. He had, was an outdoorsman, and a couple of years ago, he had some medical setbacks, and he ended up becoming very sick, and he couldn't participate in sports, and then he had a pain disorder, and you can guess it, developed an opiate addiction, gained 100 pounds, very significant health problems, and his mood took a nosedive, and he became dangerously suicidal and ended up in our program. In my sessions with him, I encouraged him to take a spiritual perspective, which he came with. And I was not acting like clergy because I'm not clergy. I was going in there as a psychologist because he had these beliefs, and I encouraged him to utilize them and to draw on them. And he was reading, next thing you know, he was reading spiritual material every day that he came up with, frankly. He talked to his pastor and helped him to get something. And he had very deep faith and believed that everything happened for a reason. That was his words. And that belief, I helped him to utilize that belief in order to lift out of his depression, and ultimately was definitely, he credited that with one of the reasons for him recovering in the end. But a lot of patients, like we talked about before, spirituality is a burden, and in a functional assessment, we got to keep our ears out for that possibility. I'll give you another case of a patient, we'll call her Kim, 57-year-old married lady from Eastern Mass, a severe anxiety disorder, and she came to us. She had substance abuse problems at McLean. Her substance abuse was completely out of control. She had to go into detox, one of the detox units. She related during our consultation that her anxiety and her alcohol use were only the tip of the iceberg. What was going on was that she grew up with a religious faith, but had gotten disconnected from that, married a man who she loved, who did not have an interest in religion, and became very secular and felt a big void inside of her as a result of this, and actually thought, and she uttered these words, that God hates her and that God was resentful of her for giving up her spirituality for a secular life. And it really felt like she was pushing against a massive boulder. She had physical pain because of it. She had a lot of depression because of it, and she was engaging in substance use and had anxiety and depression in that context. And I was very tempted to switch to cognitive restructuring don't think that way. You know, maybe there's a positive way to think about this, but I didn't. I just validated it, and I just helped her to understand and to unpack that her spiritual struggle was at the source, in her case, of her distress. And that's all I did. I just listened, reflective listening. I took out a page from Carl Rogers, literally. I didn't judge, and I was a sounding board to help her explore her own issues, her own spiritual struggles. And she realized it's related to her symptoms and she has to deal with it. And I'm not going to say magically, but a couple weeks later, she followed up. And she said she had a huge weight that had been lifted off her shoulders because she realized that this was something that she had to deal with. The third example, though, is when patients have spiritual symptoms, where their spiritual religious life is co-opting psychopathology. We spoke about this beforehand. When this occurs in the functional assessment, it's very important as a psychoeducation point to do two things. Number one, to help the patient to understand that these are symptoms. This is not prayer. I mean, maybe the patient's praying, but this is a form of psychosis. And it has to be treated as a form of psychosis, and to delineate between, yes, you might have spiritual aspects of yourself, and yes, that spiritual striving and seeking could be adaptive, positive, healthy, and a positive resource and feather in your cap, but that doesn't mean that it's not co-opting your symptoms here and that you're not experiencing a delusion or a hallucination or an obsession or a form of mania or otherwise. And the other thing is to provide psychoeducation, and we talked about this before, that the reason why the person has these symptoms is not because of their faith. A lot of patients feel resentment to their faith when they have spiritual symptoms and erroneously blame their religion for having the spiritual symptoms that they're having, when it's really, there's no reason to think that. And as a result, they actually end up developing a comorbid spiritual struggle along with their spiritual symptoms, which can make things much worse. Okay. I'll give you a couple more clinical examples here. I will. I remember the first week I was at McLean Hospital. I was a clinical fellow, and I met a lady, we'll call her Catherine, a married Catholic lady, early 30s. She had grappled with bipolar disorder for over a decade. And previously she was hospitalized on a couple of occasions. And she was managed pretty well with outpatient psychotherapy and with pharmacotherapy. But she had a recent episode that was the worst that she had ever had. She had tried to conceive a baby with her husband, and she became pregnant. She made it a full 36 weeks into the pregnancy and found out very tragic news that her baby was a stillbirth. So immediately after the delivery, she had this deep depression which consumed her. And within 3 days, though, she started to experience signs of mania. When she came in, she had these religious delusions, which were all focused on energetically. She had this energetic, mystical connection to God and spiritual ambitions, and it was all about, she wanted to become a deacon for the Vatican and religious study 14 hours a day, and a lot of long, complicated prayers, all focused on bringing her baby back to life. And our clinical approach with her was to validate her spirituality and to say, yes, this is an important part of your life, but at the same time, this was mania. And we had to tell her and help her to realize and to gain insight into the fact that she was coping with a form of psychopathology. So we collaborated with the local priest and brought them in and helped them to speak with her and to validate her spirituality even more. And from there, we helped her with standard pharmacological approaches and psychosocial approaches, as we would with any patient who had mania. And over time, she did come out of her treatment, inpatient and partial hospital, and then she was followed. I believe the PS on the story is that she subsequently had a baby, which is good news. Okay, now just to drawing things to a close here. If you want to learn more about the ins and outs of these approaches, because this is really just a smattering of ways to engage in spiritually integrated psychotherapy, but if you want to learn more about how to conceptualize for and assess for these topics, I did recently write a book on spirituality, religion, and cognitive behavior therapy, a guide for clinicians. and that is coming out this April with Guilford, from the Guilford Press, and it's already up on the website if you want to take a look. The Guilford website, that is. Okay, I have a couple concluding remarks, and then I think there's a poll that we have to launch, and then Q&A. I'm happy to answer any questions. Okay, now, this is a picture of, well, I'll tell you in a minute. People have been turning to religion and spirituality to cope with emotional distress literally for eons. What I'm telling you about today is, without a doubt, the oldest trick in the book of mental health. In fact, the most widely practiced mental health treatment even today is, any guesses in the poll? Can we show it? Any questions? The answer is Alcoholics Anonymous. 12-step programs are the most widely practiced by a long shot. And in fact, that, ladies and gentlemen, is a picture of their international convention, which meets biannually, which is so large that they have to take over a football stadium because 50,000 people show up. And as I like to joke, they're not even selling beer in the concessions. Unfortunately, though, the world of mental health, we don't fully appreciate the significance of this domain. And and needless, by the way, just in case as a point of clarification, a 12-step and Alcoholics Anonymous are fully spiritually based treatments, which I think is the reason why they are so popular. You'll note also, cognitive behavior therapy has gotten a lot more popular in the last 10 years, and I think it's very interesting that that coincided with the introduction of the concept of values, with the third wave approaches, with mindfulness, and which has been distilled from Buddhist thought into dialectical behavior therapy. That's really catapulted cognitive behavior and related behavior therapy techniques into the mainstream of mental health. Prior to that, people weren't so interested, and the general public wasn't interested, and neither was the clinician world, just parenthetically. However, by and large, the mental health world, we don't fully appreciate this domain. When we do deal with it, it's typically distilled down into very secular principles. I think we're very concerned or skittish about it, and I don't think it's to our patients' benefits. But it's changing, as is evidenced by this talk here today. And my hope, and if you will, my prayer, is that we'll have a continued trend, because if we have greater knowledge about spirituality and mental health, I think we could alleviate a lot more unnecessary suffering in this world. Okay, so thank you very much. Now are we going to do questions and comments? Yes, we are. Okay, so please type your questions and comments into the question box on the right side, and I will try to respond.
I launched our first poll. More than half of Americans pray on a daily basis, and looks like most of you have voted. The majority of you are saying true. Dr. Rosmarin, from the beginning of your presentation, is that true?
Here we go.
All right, our next poll. More than half of American mental health patients want spirituality to be part of their treatment. Is that true or false? All right, looks like most of you have voted, and majority are saying true.
Way to go, class.
All right, our next one. Spirituality and religion exert both positive and negative effects on mental health. And everybody said true on this one.
Okay.
And last one. Spirituality integrated psychotherapy is primarily practiced by clergy. A little bit more of a split on this one, but the majority are saying false. And we did just talk about that, as well as one of our questions looks like kind of speaks to that, Dr. Rosmarin.
Indeed. So not primarily clergy, but clinicians can talk about spiritual issues too.
So it looks like we have 6 questions. Our first one, what are the statistics on clinicians who have no spirituality but treat those who do?
Yeah, it's a great question. I get that a lot. There aren't a lot of statistics. There was one paper that I know of which was published in, it's a while back, at least 20 years, 92, I think, 25 years, by Rebecca Probst. What she found was really interesting. She crossed 4 conditions in her study. It was actually published in the Journal of Consulting and Clinical Psychology. It was on depression and depression among religious individuals. The 4 conditions were this. She had religious cognitive therapy practiced by religious clinicians, religious cognitive therapy practiced by non-religious clinicians, non-religious cognitive therapy practiced by religious clinicians, and non-religious cognitive therapy practiced by non-religious clinicians. Okay, 4-arm randomized control study of depressed religious individuals seeking religious or non-religious cognitive therapy practiced by religious or non-religious clinicians. Got all that? Okay. What she found was that the religious cognitive therapy was better than the non-religious cognitive therapy. Okay. Then, when she went to look at the specific effects, what she found was the non-religious clinicians practicing religious cognitive therapy were actually driving the entire effect and actually doing a better job than the religious clinicians practicing religious cognitive therapy and the non-religious or religious clinicians practicing non-religious cognitive therapy. So bottom line is that it doesn't matter what you believe at all. You could be a perfectly irreligious clinician practicing spiritually integrated therapy because you understand that this domain is functionally relevant to your patients, you're sensitive about it, you are thoughtful in the way you approach the subject, you give your patients an opportunity to discuss it in treatment, and you integrate it effectively into the treatment process. I'll tell you just another idea. I don't think you have to be homosexual to treat homosexual patients. And I don't think you have to be an African American to treat African American patients. So why would this aspect of diversity be different to any other? So.
Great. Our next question, in regard to spirituality and psychotherapy, it seems that you are using the individual's spiritual inclination to enhance the otherwise conventional psychotherapy. You differentiated this from pastoral counseling in that the goal of the former is to achieve spiritual goals or to be more spiritual. What happens if an individual identifies as spiritual, possibly with a specific religion, but that relationship is tenuous or troubled? You mentioned another case like this, so how might you proceed?
Yeah, wow, you guys are asking really great questions. It's a good group. So cautiously, I would proceed cautiously in that case when I think that their religious beliefs or their practices are creating distress. But my role as a clinician is to be able to call them on that. Often what I've found is that clergy collaboration helps me to facilitate that. And the clergy are usually saying, yeah, that person is not practicing our faith. They are doing something which is excessive. They are doing something which is outside, and they are conflating that and thinking that this is what everybody believes and this is what everyone is doing, but that's not true. So typically clergy collaboration is helpful. There are cases where it's not. Oops. I don't know if I just messed up my screen. Can you guys still see?
Yep, we're good.
Okay. There are cases where that's not the case, and where you're really up against a wall. Fortunately, those are few and far between in my experience. And when they do happen, you have to assert your position in a way that's going to be effective for the patient, without being combative, hopefully in a collaborative and as positive a way as you can.
All right. The next question, is it important to match a clinician and client's spirituality beliefs?
Yeah, so great question. And no, I don't think so. In fact, I think that in many cases, secular clinicians can provide just as good, if not better, spiritually integrated therapy than others, because they're able to see it from a different perspective than the patient. As long as they're going to take the time to be informed about the important spiritual issues and take this domain seriously like they would any other domain. As long as you're respectful and thoughtful in your approach, you really can't go wrong.
Okay.
Oh, I'll add one more piece there.
Sure.
Sometimes patients want to have a clinician who shares their belief, or at least they'll state that at the outset. I've found in such cases that discussing it with the patient and conveying a respect for their beliefs and an interest in integrating them into treatment is enough. But in some cases, really the patient just says, no, I really want someone who is from my faith community. And then, of course, our hands are tied. But
okay.
Yeah.
This one, I encounter a large group on nones who often state that their belief is in a larger power, but it's not important to them. Any resources for a structure to offer them if they so desire?
Not sure I understand the question. You want to repeat it to me, maybe?
Yep. I encounter a large group of, it's like none, but with an S, nuns, like 0, who often state that their belief is in a higher power, but it's not important to them. Any resources? Says the group of people who don't identify with a particular religion, but say they do have spiritual belief.
Oh, nuns, like N-O-N-E, like they don't have a spiritual faith. They don't have a religious affiliation, but they have a spiritual faith.
Yes.
Yeah, I mean, that's half of my patients in Massachusetts. That's very common. And I'll tell you what we do. We take I skipped over it with my slides because I saw I didn't have time. But we will give them a menu of spiritual beliefs that, well, I call it a menu. It's really a handout with different spiritual beliefs that other patients have found helpful in the past. Things that are taken from Eastern systems and Western systems, really a conglomerate of different spiritual beliefs, and hand them to them and say, hey, would you like, are any of these of interest to you? Are any of these consonant with your value system? We do the same thing with practices involving really an 8.5 by 11 handout. That one might be 2 pages, but maybe it's 1 page or 2 pages. I can't remember. We have a handout which shows different spiritual and religious beliefs and practices, and then provide that to the patient and say to the patient, is there anything here that you'd like to do? Or are there any of these beliefs that you'd like to draw on in your treatment? And typically they will find something there that they like. And if they can't think of something off the page, it'll usually generate some sort of idea within their minds.
Wonderful. Are there any methods to treating clients in a spiritual way other than having them talk about it or go to community groups?
I don't know if I would want to try any methods that don't involve actually directly speaking to patients about it. There are self-help methods that I would be comfortable with. There's also referring them to clergy to speak about it. I think it's important for clinicians to be able to talk about spirituality with their patients. So I really think that's the best approach. I suppose there are other approaches if need be, if it's impossible to communicate about these things for some reason, or if the clinician's really not comfortable, but I'm not sure those would be my go-to strategies.
Let's see. Clergy collaboration is terrific. Also, Freud was persecuted by living most of his life in the shadow of a Catholic cathedral while suffering from the rise of Nazi Germany, which drove him from that home. Wow. I don't know this word. I'm sorry. The tripartite nature of Judaism caused him pain and passion. So I think that was just a comment from your earlier.
Yeah, the comment about Freud. A lot of people want to rescue Freud from the ashes, and I will tell you that there's a lot of good in what he did. I mean, none of us would be sitting here having this discussion if it weren't for Freud and his work. When it came to spirituality and religion, though, I beg to differ with his approach, and I don't think it did a service to the field. I think it set us back at least 50 years.
Okay. Are there any publications you would recommend to enhance a clinician's knowledge of different religions in order to better understand their client's spiritual and religious beliefs?
I'm going to make two comments on that. Yes, there are. You can check out the Duke Spirituality and Health website. The URL is escaping me, but if you just look at Duke University Medical Center, Spirituality and Health, there is a very rich resource website. The head of the project there, Dr. Harold Koenig, has a number of books that have just come out on Amazon.com on different faiths. And they're basically a primer about different faith groups which were written for healthcare practitioners. However, and I think those are great resources, and I think that everybody should be familiar with them. However, I don't think it's necessary to become an expert in world religion to provide spiritually integrated therapy. What patients need is a thoughtful mind and a listening ear, and somebody who's willing to go into this domain with them. And I don't think restricting or encumbering that process by requiring patients to have, clinicians rather, to have extensive knowledge of religious systems is either necessary nor indicated.
Okay. And then our last question is just back to that handout that you were mentioning about the higher power question. If that's a handout that you could share or give us the resource to find.
With pleasure. Erin, I can either send it to you and then people can contact you, or you can take a look at the Spirituality and Mental Health website, Spirituality and Mental Health Program website at McLean Hospital, and find me there, my contact information, or it's on your slide, actually, the last slide. Send me a note, and I'll have my RA fire off a copy to you, and it's not a problem at all.
Perfect. All right. Couple just thank yous that it was a great presentation, and thank you for sharing that handout. But I think unless anybody else has a question that they want to put in here, we've gone through all the questions we have at the moment.
All right. Well, thanks for having me. It's been great to be part of your program here, and appreciate the opportunity.
Yes. Well, I just want to thank all of you for attending the session, and thank you, Dr. Rosmarin, for this presentation, and it was fantastic. Thanks to the Iowa Department of Public Health, the Iowa Gambling Treatment Program for sponsoring this, as well as the other trainings coming up in our series. If you want to learn more about those, go to the Training Resources website. An evaluation is going to pop up, be launched, as well as sent a link in an email after the conclusion of this. The surveys are going to help us with our future training. So it would be great if you could give us that feedback on how this went. If you have any suggestions for other webinars as well, we'll go ahead and use that in the future. And then your certificates will be available on the Training Resources website under your individual account within a couple weeks after this training. Dr. Rosmarin, can you go back one more time to your slide with your email so people can look at it?
There you go.
All right. So I think we're wrapped up. I just looked again, a couple more thank yous. So I'll just give you guys a second to look at that slide with the email. You can also go onto the Training Resources website and download the handouts for this presentation if you want to go find that. And yeah, if you don't have anything else, Dr. Rosmarin, I think that we are concluded.
Okay, thank you so much. Have a wonderful afternoon.
Thank you.